Welcome, welcome. It's so good to see everyone. We are so excited to be here on Wednesday, June the 1st. I have no idea how it's already June, and it's been 6 months since the new year. I looked at my phone this morning and was just like, how is this possible? So wild and crazy. I feel like last year and the last 2 years with COVID sometimes went really slow. And wait, Chris, is it your birthday?
It was my birthday last Thursday.
Oh my gosh, I missed it. Happy birthday.
Happy birthday.
Thank you. Thank you. Thank you. I know it was so cute. They decorated. You can't see it, but I have like birthday balloons.
I
And
love it.
look at this. This is cute. They got me like a piñata
Oh, piñata.
and
So
a bear
cute.
and balloons.
Aw.
So yes, and I'm doing the whole Paris Hilton thing. So I'm doing stuff for my birthday tomorrow, Saturday, Sunday. You know, we gotta like have
Live
a
it.
birthday month.
That's right. That is right.
We're
Let
celebrating
it
at the
long
OCD
live.
Walk. The IOCDF Walk is this Saturday for us in
Yay.
OCD SoCal, so we're going to be celebrating my birthday there. Like, I'm going to be that annoying person. Everybody will know it's my birthday. I'm at the grocery store. I'm like, here you go. Oh, it's my birthday. So that's just me.
I love it. I love it. I love it. Well, happy birthday. So good to
Thank
see
you.
everyone. Please make sure to tell us who you are and where you're joining from. We are so excited to be here. This is a really important topic. Today, we are going to spend some time focusing on medication, and it's questions that Chris and I often get, and you always hear us say, we're not psychiatrists, we'll defer to the professionals. And, you know, we can do clinical stuff all day as far as behavioral interventions, but we're really cautious. And so today, we're really going to focus on medication adjustments, augmentation, questions, kind of you name it across the board, all those questions. And we have such an incredible expert with us who I'll introduce in just a second. Before we do, typical housekeeping, please remember that this is not intended to replace therapy and shouldn't be used or considered for your individual therapy. Instead, we work to provide broad psychoeducation, resources, and support that we hope you'll find helpful in your journey toward your individual treatment. Of course, if you're feeling suicidal, unsafe, we ask you to call 911, go to your local emergency room, or call the suicide prevention line at 1-800-273-8255 here in the U.S. And of course, to follow your local resources if you live outside the United States. Please remember that IOCDF and our events we are not a crisis hotline, and we're not intended to serve those in crisis, but there are individuals and places that are. So please follow those leads to make sure you stay safe. We, as always, have a million updates. The most important things are to make sure you're checking out our community conversations, which are every Tuesday at 7 p.m. Central Eastern Time, 6 p.m. Central, 4 p.m. Pacific, and that you're also joining us on Wednesdays, where Wednesdays it's really about experts and professionals, whether it's behavioral interventions, clinical interventions, medication, or our research roundtable. That happens every Wednesday at noon Eastern Time, 11 Central, 9 a.m. Pacific. So we are so excited. And today, as you know, it's an Ask the Expert. And so today we're really focusing on medication and OCD, something that we get so many questions on. I have questions on that I know I'll want to throw in there. Chris probably will too. We have some pre-submitted. And of course, we will always answer any submitted questions that you have. So if you see on your right-hand side, there's a pane that you can put your questions, and we will do our best to answer them. I want to introduce our incredible guest today, who's Dr. Carolyn Rodriguez. Dr. Rodriguez is the Associate Dean for Academic Affairs at Stanford University School of Medicine and the Associate Chair for Inclusion and Diversity in the Department of Psychiatry and Behavioral Sciences. She's also a consultation liaison psychiatrist at the Palo Alto VA. As the director of the Translational Therapeutics Lab and associate professor in the Department of Psychiatry and Behavioral Services, she leads studies investigating the brain basis of severe mental disorders. Her landmark clinical trials have pioneered rapid-acting treatments for illnesses including OCD and PTSD, two important diagnoses that y'all hear us talk about all the time. And so use this time with this incredible expert to ask questions. Carolyn received her bachelor's in computer science from Harvard, followed by her MD from the Harvard Medical School and MIT, and she has a PhD in neuroscience and genetics from Harvard. She's born in San Juan, Puerto Rico, and now lives with her husband and 3 children in Palo Alto. So none of our education or background can compare to yours, Dr. Rodriguez, but we are so excited to have you here. And you know, you and I have worked together and shared the screen on lots of different talks, and I just wanted to say thank you, because I feel like there's not a lot of psychiatrists who've dedicated their career to OCD and PTSD. They're out there. There's few and limited, but for those of us in the community, we are so grateful for you and the work you've done and the way it helps advance the treatment of individuals living with OCD. So welcome. Thank you for being here. And if you want to take a second to tell us a little bit about why you love or enjoy doing work with OCD.
Mhm. Definitely. And I just want to say thank you to you, Liz and Chris, for having me on the show and for doing these live streams. It is so critical, the work you're doing in therapy and outreach. As you guys know, it can take up to 17 years for individuals between the onset of symptoms to get into treatment. And there are many factors for that, but I think one is just recognizing the signs and symptoms, overcoming stigma, and you guys are really pioneers and really leading the way. And so for me, my passion really comes from seeing that delay, seeing individuals struggling with symptoms, and endure a lot of private suffering, and not reaching out for help when they have difficulty. And so I'm really committed to that. As well, my research focus is for individuals who have tried first line treatments like cognitive behavioral therapy with exposure and response prevention, and medications like serotonin reuptake inhibitors, and they're not helped. But the good news is that a majority of individuals will be helped by these first line treatments. So I'm happy to, answer any questions and just be a resource for discussion.
Yeah, Carolyn. Well, I'm excited. I was just looking and we have a lot of med questions and we already got one live. But before we jump into those, what I'd like for you to kind of start off with is for many people, they're not sure. Like you said, it's been a long delay for them to get help and they're not 100% sure even where to start. What are sort of the first line medications? Like typically if someone's first
Mhm.
seeking out medication treatment and medication intervention, what would be some of those first line things that a psychiatrist or a prescriber would start with
Right.
for
So,
OCD?
yeah, thank you for that question, Chris. So, what I would say is, even though I'm a psychiatrist and pharmacologist, I would start with cognitive behavioral therapy and exposure and response prevention. Behavioral interventions are really fantastic, and they don't have the medication related side effects that medication do. And so that's where I would begin. First, diagnosis. Second, really explaining what behavioral therapy is, letting people, giving people referrals and resources to talented therapists. If you don't know where to go, the International OCD Foundation has a wonderful resource for you can put in your zip code and find a therapist near you. For some individuals, they may prefer medication. They may have very severe symptoms, and sometimes I might recommend doing both at the same time. And so that class of medications that I would recommend, and that has been studied a lot, is called serotonin reuptake inhibitors, or SRIs. And that includes a drug called clomipramine and a class of drugs called selective serotonin reuptake inhibitors. And those medications adjust chemicals in the brain, and a person will meet with a psychiatrist weekly, biweekly, or on a monthly basis. And the medications need to be taken once or twice daily to work. And it'll take about 6 to 10 weeks at the right dose for the person to feel better. And the medication may be gradually increased. Those medications are not addictive, and some have physical side effects that will go away on their own. But if they don't, the medication can be lowered, and it can take about a few weeks to get better.
And what would you say? There's a lot of people that are hesitant with medication. Some of the biggest things that I hear, well, actually, what I want to do is take a step back. And first of all, thank you so much for mentioning the behavioral treatment because, my thesis in grad school really focused on like why people aren't getting better from OCD or getting the frontline treatments and evidence based. And one of the big ones is many people that went to a prescriber weren't being told that there was even behavioral therapy out there. And I've had plenty of clients come to me and say, I've been on medication for OCD for a decade, didn't know that existed. So thank you for that. A lot of clients will have fear around it. They fear that the medication is going to change them. They fear that they're only going to get better from the OCD strictly because of the medication. There's a lot of stigma around being on medication. They're really terrified of going on it. How should, or how do you maybe address those kind of fears that people may have coming in to get on medication?
Yeah, well, I think there's maybe 2 points in there. So one is stigma, and the other is just maybe something like efficacy. Do they work? Why should you do them if they're side effects? So for stigma, I would say that individuals that have intrusive obsessions, taboo thoughts are individuals that may have the most sort of feelings of embarrassment in terms of reaching out to providers from what I've seen. But like you said, there are people who've dedicated their lives to OCD. If you find an OCD expert, nobody will be surprised about the symptoms. These are very, very common symptoms that people face. And what I would say is, like, if your uncle was having a heart attack, you wouldn't tell them, oh, you don't need to seek care. You need to just deal with it on your own. Or you wouldn't expect your uncle to be embarrassed about their heart condition, right? So you would recommend that they go to the doctor and get treatment. So it's the same thing here. There is something that is impairing your health, and it's important to reach out for help. So that's one side. The other is, just information, right? The International OCD Foundation has a beautiful webpage that is dedicated to what is OCD, what are the signs and symptoms, and somebody comes into my office about medications, I'll tell them that our studies show that 40 to 60% of individuals who have an adequate trial of an SRI will have on our average a 20 to 40% reduction in OCD symptoms. So, although many respond, few achieve minimal symptoms with an SRI alone. So, in this case, adding exposure and response prevention can be helpful in improving outcomes. Um, the What I would say in terms of the fear that of side effects is that there is the possibility to titrate up and titrate down, which I mentioned. So if somebody has sexual side effects, a headache, dry mouth, any of these things, it can be titrated until the maximum tolerated dose. And then you have a lot of things that you can do to add on. It's called augmentation. You can augment with cognitive behavioral therapy. You can augment with other medications. You can also switch to other SSRI medications. And just because you've had side effects with one doesn't necessarily mean you'll have side effects with another.
And for those people, real quick, Liz, I think a big one that I heard a lot when I told people about the live stream in my own practice and was like, please watch it. One of the things, I have a lot of clients that are just not willing to take it. And I think it's because they don't know how it works. Obviously, we could do a whole separate like live stream just on how medication works. But how would you briefly explain it to someone who's afraid, like, this is going to change me, or they think it's going to be like a numbing effect versus the way that it works? What would be like a quick way of describing how the medication works that might reduce some of the fear behind taking it?
Yeah, no problem. So we have nerve cells in our brain that transmit information and communication, and between those nerve cells, there are chemical messengers called neurotransmitters that tell another neuron to fire or not. And serotonin reuptake inhibitors basically, like, as the serotonin is being released from the messenger from one cell to the other, it goes through the sort of middle area. And a selective serotonin reuptake inhibitor prevents the serotonin from being taken back into one cell, and it basically raises the level of that chemical messenger. And so this has been shown through research studies that these types and this class of medication to help decrease OCD symptoms. So, I hear that one of the concerns is it going to change my personality. I That has not been my experience. You people remain, who they are by core, and the idea is to target and decrease the OCD symptoms. People will have side effects. These medications also affect mood, so it might lift your mood. And what I would say is, if there's any indication that you don't like the side effects, you can stop. You can decrease the medications with your therapist.
Totally. And, I think One of the things that so two of the things I hear a lot that I want to touch base on are, number one, do I have to be on medication forever, right? So we know that the gold standard is often a combination of medication and behavioral therapy. And I love that you're emphasizing that like behavioral therapy is required, right? We have to be engaging in ERP and behavioral therapy. And then the second piece is there an option if somebody starts medication for them to consider tapering off of it later? And what might that look like, especially when we're talking about kids and parents wondering if it's something that they would have to be on forever or if it could be an option as they progress in treatment?
Oh, definitely. So, my mentor Blair Simpson did a whole research study on this, and I think it was recently published. It's attaining and maintaining wellness in OCD, and what they looked at was this question. So, if you're on an SRI and you add on exposure and response prevention and you get better, do you need to be on an SRI? So. They randomized people then to continue SRI or blind um, to continue with like a placebo medication. And I will let Dr. Simpson sort of, provide in depth about her study. But it did look like that with therapist and psychiatrist supervision, you can come off of the medication. Now, some people in the study did have relapses, and so that's why it's important to be monitored by a professional, and obviously it's going to be a case by case study. But I think the study that Dr. Simpson and Dr. Foa conducted was successful in basically debunking that myth that perhaps you have to be, once you're on medication, you have to be on that medication forever. Again, the caveat is that each person is an individual, and these are like averages for studies. But I think it provides a lot of hope and promise, and it also underscores and emphasizes again the power of cognitive behavioral therapy and exposure and response prevention, and how that really can be a toolkit that you can use to continue. Once you have that training, to continue to use, and then get booster sessions as you need to.
Yeah, I just want to quickly add in is like I was able to titrate off of medication. I tried treatment for about 6 months without, and just I did well, but when I hit some of those harder things, it was really hard to push through, and I went on medication. And then after about a year, when I stayed on medication for a while, but then there was like a year where every time I saw my psychiatrist, we pretty much had nothing to talk about. So we tapered down slowly, and symptoms didn't really rush back. But I will say, and I'm so glad that you're emphasizing it, it was the skills that I learned in behavioral therapy that really allowed me to maintain those gains while off of the medication. It was, knowing when new situations jumped up, what to do in that situation. And the treatment that I did years ago worked and worked and kept working.
And the big thing, I always want to talk about and emphasize is that it's life in general. I have a 1-year-old, and I've learned that life is with a kid feels like just a science experiment. Like every day it's like, well, I don't know, like we'll see. Right. And that's kind of our life too, right? Is the thing I want to push is let's not be closed-minded or rigid about how it's going to look and what it's going to be. And, if I get off meds, I have to stay off meds. It's like, the thing I always tell my patients is like, let's try it, and we can try what you want and what makes sense, but let's be open-minded and be able to continuously assess if what we're doing is working, right? So there is zero harm in staying on medication long term. We know that. We can talk
Exactly.
about that. But for some people who want to get off, if you're able to, we can try that as well, right? And I will have a lot of patients who will come to me and say, Liz, I want to try ERP first before I consider meds. And my response is always like, absolutely, that's your choice. However, all I ask is that you be open-minded, that if we might need some extra help, and if we're not making progress, I want you to trust that I'm going to be sharing that with you, and we need to be thinking about it, and we need to at least have it on the radar as something we might consider, versus having these rigid, like, I never will. My second question I want to talk about, because I get this all the time, is perinatal medications, and really the anxiety that for a lot of us in the perinatal period or postpartum, we have a lot of anxiety around OCD, anxiety increasing, and we know that it often does. But then we also have anxiety around, is the medication safe, and what can I take and what can I not take? And so I'd love to hear a little bit about what might often make sense, and how somebody, if they're in that period, can navigate medication safely with pregnancy or postpartum.
Absolutely. I think this is a great question. And, I think that it is important to have those shared decision making, Liz, that you're talking about to really understand what are the pros and cons, what's the latest in the field. If possible, to reach out to somebody who is a perinatal expert and has experience. I know there's, been recently wonderful reviews that have come out on medication, pregnancy, and mental health that can be referred to. And what I would say is that if I encounter this question, I refer people to an expert who really is on top of the literature and knows what the latest recommendation is. So that may be something that and I'm happy to help facilitate if you wanted an expert on that topic to come and speak on that, because it is a topic that is in that space of shared decision making and transparency.
100%. And I love that. I love that the answer is really like work with your psychiatrist to talk together about what you're comfortable with and what they think makes sense. Because again, this is where you're going to hear Dr. Rodriguez say things like it's not a one size fits all, right? This in medication isn't. And I want to hop into the last question I get all the time before we hop into pre-submitted, Chris, and then live, which is augmentation and names and classes of medications causing a lot of anxiety and stigma. So we often will see antipsychotics be augmented for OCD treatment. And I find that there's a lot of anxiety when it's like, what do you mean you're putting me on an antipsychotic? Like, I have OCD, I don't understand. And for some people, that in and of itself is a core trigger for them, right? Like, what if I have an undiagnosed mental health condition? And so it could also be triggering OCD in addition to being like, why are you putting me on that? Can you spend just a little bit of time describing what some of the augmentations might look like and why? So like, why would you consider augmenting an antipsychotic? With one?
So, right. So, I will say there's a really great resource, and I had sent the link to Skyla before. There's the Anxiety and Depression Association of America. I worked with my mentor Blair Simpson, Moira Wren, a bunch of other people on this kind of publicly available clinical practice review. And so if the link is there, you can kind of review this, at your leisure, or give it to your provider. But we gave recommendations basically for first line treatments, again starting with exposure and response prevention for adults and for children, and it breaks them up into first line psychotherapy, first line pharmacotherapy, so it's medication treatments, and then what is recommended, what is the evidence base for other things. So the question to ask yourself, if you've tried something and it isn't worked, did you try the first line treatment, SSRIs and exposure and response prevention? The second is if you have had no response to a medication in that class, try switching to another one. If that isn't working, you can consider switching to clomipramine. You can also consider switching to venlafaxine and mirtazapine. They're not FDA approved for OCD, but that's another one to try. Then you can consider adding an antipsychotic. My one caveat for antipsychotic, so it does have good evidence base, but what I would say is that what I see sometimes is that people add it onto a regimen and it doesn't really help them and they stay on it. And antipsychotics, it's really important for people to know that it has side effects like weight gain. It can have a side effect of tardive dyskinesia, where you have like a kind of a ticking that can actually stay there, and something called neuroleptic malignant syndrome, which is like a really high fever, and people sometimes can be hospitalized. And so, because of that negative side effect profile, you really have to be aware of these potential side effects and only be on an antipsychotic augmentation if it's really helping you. So really talk to your therapist, like, what are the pros and cons of this medication and should I continue on it? We already talked about adding on, obviously, exposure and response prevention if you're only having a partial response. There are other classes of medications called D-amphetamine, memantine, pregabalin, topiramate. So again, I won't flood with a lot of different alternatives. They're written down in those guidelines. But just the bottom line is that there's a lot of hope. There's a lot of different things that have maybe not as much evidence base as the first line, but there are randomized studies and there's beginning to be evidence base. So working with your therapist and your psychiatrist together, there are a lot of things that you can try.
A quick, oh, go on.
Go,
Liz,
Chris.
sorry.
Go ahead.
I was going to say a quick question that I got virtually before starting today. What can people expect from the medication? I think sometimes people don't understand or know what to expect when it comes to relief in symptoms. I think sometimes people either expect this like overall, like completely elimination of symptoms. Some people don't know. What can the average person expect, just so that somebody who's starting on medication may have a little bit of an understanding what to expect from taking medication?
Oh, definitely. That's a great question, Chris. So, on average, people will have a 20 to 40% decrease in their symptoms. So, complete cessation of OCD symptoms is rare. But as Liz was talking about earlier, that may be that sort of decrease, that intensity, can help sort of open you up a little bit more for things like cognitive behavioral therapy. And some people are just are worried about the treatment. What is it going to be like? And just having the medication on board to kind of help decrease and get that extra little help to get started and to see that it's really, really effective is important.
And, I think that what I want us to hear overall is treatment in general, right? Chris and I talk a lot about ERP, CBT, what it looks like, how it's about being flexible and it's about figuring out what works for you, right? Even if we talk a lot about this, is like ERP with one provider might not be the right fit for you, but with another provider, it's like, oh my gosh, it clicks. And medication is something that, again, for some people, they respond well to one medication, someone else might not, and some have, right? And so medication, behavioral therapy, it's really about being flexible and figuring out what works for you. The last thing I want to talk about combined before we hop into pre-submitted is, can you talk for a second, Dr. Rodriguez, just about the critical nature of having a collaborative team? So how important is it that your psychiatrist and your clinician, your behavioral therapist are talking and that they're communicating and that they're working together and making sure we're not working in silos? And why have you seen that to be useful or not?
Yeah, absolutely. And Liz, please call me Carolyn.
Sorry, it's hot. I can't.
I could call you Dr.
John Grayson gets mad at me about this too, and I'm like, I can't.
No, please, no, please, Carolyn. So I think, Liz, you hit the nail right on the head, which is that what I'm talking to you about is kind of straightforward OCD, but nature is not carved at its joints, and a lot of people can have co-occurring PTSD and depression. And there are different treatments, therapies, medication for those kinds of things. Some people may have comorbid hoarding disorder, BDD. There are a lot of things in this space that require attention. They require the right targeted treatment. And so being in coordination with more than one provider to help and understand and phase the treatment can be really helpful. And in fact, I believe it's critical. You want that when you're, looking for a therapist and when you're looking for a psychiatrist. And again, you talked about good fit. Look for a second opinion. Ask them about what is their philosophy. This is in a sense a shared. You want to feel like your psychiatrist and therapist are partners with you in your care, and that you're really, driving and getting in the information. So you may look to people, like, I know this is called Ask the Experts, but I firmly believe there are no experts. You're the only expert in how you feel, what your symptoms are, and what you need. And I'm a researcher. We're on the cutting edge, and I have a lot of hope, but we have not figured out how to 100% cure first time,
Yeah.
OCD. I aspire to that, and that's what keeps me up at night, and that's what drives me. But we're not there. And so we have data that we generate and these clinical trials, But you also need to take those trials with a grain of salt, because the people who go into the research study are very, specific kind of person. And so it's answering that specific study. We don't have these studies with individuals who have comorbid bipolar, right? Individuals that they're excluded from a lot of our research study. So again, you have to work in concert with your psychiatrist, your therapist, and really trust what is right for you.
100%. So let's hop into pre-submitted. And Chris, why don't we just go through these and then we'll go through live versus back and forth, if that's okay. And
Yeah, whatever works.
Carolyn, feel free. If there's any that you're not comfortable answering, you can always defer. So the first question is, can you please speak to common medication combinations for people with depression, OCD, and ADHD?
So what I would say is the class of SSRIs is, really a good class for OCD and depression. One thing to highlight is that if you're on a medication like this for depression, you actually need higher doses and for longer periods of time than depression. So depression, you can stay at sort of the minimally recommended FDA dose and feel some effects by 2 weeks. But in OCD, we're looking at 4 to 6 weeks, at the maximally tolerated dose. And for some people, it can be out to 8 to 10 weeks.
How about the ADHD component? Yeah, I just wanted to touch on that because that's a big one people ask about.
Yeah, for ADHD, so Dr. Larry Curran did a really interesting study looking at D-amphetamine versus caffeine, high-dose caffeine, and he thought high-dose caffeine would be a good control for D-amphetamine. And he was surprised by his own findings that both were actually really helpful for decreasing symptoms. And so I know of at least one randomized controlled trial of D-amphetamine that has been very helpful.
Awesome. Next question is, I'm waiting to get some intense therapy for a couple of weeks. My therapist doesn't think once a week is enough. I'm also on, citalopram. I don't know.
Citalopram, yeah.
Citalopram, I'm sorry.
SSRI, yeah.
20 milligrams. I haven't, for some reason, heard that name yet, but I'm willing to try anything. I'm not sure what the question would be here. So I guess maybe we could focus a little. Yeah, however you want to field it.
Yeah, it's no problem. So citalopram is an FDA-approved medication for OCD. But I would say that the FDA recently came out with a black box warning that for adults older than 60, you don't want to use more than 20 milligrams a day, and for 40 milligrams a day for adults. So I would not recommend, like the other medications, for example, something like fluoxetine or Prozac, you can keep pushing up the dose between like 20 to 80. But for citalopram, just want you to be mindful of that cap. And so that's a medication that if you're on and is helping you, want to augment. And it sounds like you're augmenting with exposure and response prevention. And what I would say is, just like you're increasing the dose of a medication, you can actually increase the dose of cognitive behavioral therapy by doing it more than once a week. You can also increase the dose by different kinds of modalities. So one question to ask yourself if things aren't working is, am I in the right setting for treatment? So most people will be helped by outpatient treatment. But there are also things like intensive OCD programs that can go not only twice, but 3 times a day. There are also home-based treatments for individuals that have difficulty coming into the clinic. There's residential treatment, and that's for interdisciplinary or multidisciplinary teams, and people can titrate pharmacology and cognitive behavioral therapy with close monitoring over a period of months. And then finally, there's the hospital level of care. And that's, if you're having difficulty providing self-care, or, you need observation, or the co-occurring conditions in and of themselves need hospitalization.
Awesome. Next question is about weight gain and medication. So, just what do you do if you gain weight? And we know that it's a side effect for some medications that people struggle with. And so any recommendations on how to handle that, and maybe if there's some medications that they should consider instead of others?
Well, certainly I talked about antipsychotics. That is a side effect. Um, one of the things that we've seen with other disorders that require antipsychotics is very close monitoring of blood sugar, hemoglobin A1C, um, dietary management, exercise programs. So a lot of like sort of programs that are kind of stitched in to the treatment to try and help with weight management. I don't know of any medication that would help with the weight loss or to block the weight loss effects. Although I think that would be really important area of research going forward.
I think the question would more just be, is there certain medications that don't have as high of a chance of weight gain as a side effect?
Yeah, well, I think the SSRIs have less chance of,
Yeah.
of weight gain than an antipsychotic. And there haven't been, as far as I know, head-to-head comparisons of the different SSRIs and careful tracking of weight gain. So I think the jury's out.
Definitely. And again, this is where it's kind of a trial, right? And you have to see what works for you and what doesn't, and weigh out the benefits and the costs of anything. Sorry, I lost my document for some reason. There we go. So this is an important question that I was actually going to ask, and so I'm happy that it's here. My 30-year-old son has struggled with OCD for years and is reluctant to get help. When he did finally call an OCD, the therapist told him that since he was on a benzodiazepine, ERP would not work well, and that he should talk to a psychiatrist to get off them before doing ERP. I was discouraged for him to hit a brick wall when he finally reached out. Would you agree that benzodiazepines do interfere with ERP? And would this be the response from most therapists if he reached out to someone else?
I don't think I've ever come across this scenario or this question.
So we come across it almost every
I
day here in residential, and so
Same.
I can share my thoughts as well.
Is there a study that shows this? I don't know of any research study that shows that benzodiazepine blocks. I mean,
Yeah.
I'm curious to your thoughts, but
So I'll share
my answer would be exposure and response prevention works, and is benzodiazepine an FDA approved medication for OCD? No, I would go with the SSRIs, but some people need a little help, temporary help,
Yep.
for anxiety, and so I think it would be okay. I can see a scenario in which somebody had a benzodiazepine, did enough to sort of decrease the anxiety to start it, do exposure and response prevention, do beautifully on it, and then maybe require less benzodiazepine.
Yeah, I think there's always scenarios that work. I think the biggest concern we have as a residential program when I'm looking at admissions and when I'm thinking about somebody coming in is what function does the benzo serve and what is your relationship with the benzo? So if I find that you are not willing to taper off benzos and you're not willing to tolerate any level of anxiety or distress, broadly speaking, that's going to go against the treatment model we have here in residential settings, right? Because we are trying to teach you that anxiety is not dangerous, that you can manage spikes in anxiety, you can manage distress without needing external tools, right? We don't let patients smoke during ERP blocks. We don't let patients take benzos during ERP blocks because we don't want you to have to teach. We don't want you to teach yourself that I need this external tool to feel better, right? We want you to be able to kind of ride the wave of anxiety. With that being said, would I tell a patient that they're not allowed to do ERP if they're on a benzo? No, right? I wouldn't go to that extreme. However, I definitely would have a conversation about what message could benzos be sending to you in your relationship with anxiety, and what are your long-term goals? If you have no interest in getting off benzos and you're always going to take them, it can interfere with ERP in my mind a little bit. Chris, I'd love to hear yours, just because if anxiety can't really get to a certain level, we can't teach you behavioral tools because you're taking a benzo maybe during ERP, before or after ERP. Again, you're still teaching yourself that you need that medication or that fast-acting pill to be able to have relief compared to being able to ride the wave. I think what you described, Carolyn, is perfect, is like, if the goal is that the benzo might get you to a place where you're willing to do treatment and then we're able to slowly taper you off. I think that's a very different story than us relying on the benzo to feel better or to reduce our anxiety. Chris, what are your
Yeah,
thoughts?
what I was going to say is like when I get worried is when a client comes in and they've been on benzodiazepines, let's say for like 3 years, 4 years, 5 years, and the prescriber that they're working with has kind of used it as an SSRI, basically like, hey, you're just going to take benzos forever. And then what I notice is when the client does inevitably start to taper down after treatment, if they've been on benzos long term, it's almost like the volume is turned up and suddenly it's just too tough. And it's almost like they're, early on, it would be like, did they even go through treatment? Because now that they're off the benzodiazepine, it's like the anxiety is too loud and they're reverting back to compulsive behaviors. So what we found, because we have an intensive outpatient program, is what Liz was saying is like working with a provider, obviously not us, but working with their prescriber to say, okay, is there a way that they could start to taper down and see if they're able to manage their anxiety through the behavioral therapy versus the benzodiazepine. And so that usually works really well, is like the client's willing to taper down and step up the ERP. Because like I said, for some clients that have been on it for long term, they have the mentality that I can't handle anxiety and I need that. Whereas, like you said, because SSRIs aren't fast acting and addictive, clients on SSRIs don't have the same mindset. It seems to be very different. I have clients that will leave the session of an IOP and immediately take a benzodiazepine to handle the anxiety, and therefore you're not learning distress tolerance, or that you are strong enough to manage your own anxiety.
And it's no different for us if you're going and vaping or you're smoking marijuana, right? But like anything where you're using an external tool to reduce anxiety right away, even if it's a ritual, right? We don't recommend it, because behaviorally, what are we teaching OCD and anxiety? It's like that we're scared of you, we can't tolerate you on our own, right? It's the same with panic disorder. Like the treatment for panic disorder long term is not benzos, right? It might be short-term treatment or relief, but again, it then becomes addictive. And what we're actually teaching ourselves is that when we feel anxiety, we have to have a benzo accessible or be able to take one. So, right, I think it's a really good question. I think that I don't know personally any providers who would say I wouldn't be willing to start ERP, right? Or like it's a hard no necessarily. But I do think that there's some alternatives, right? So correct me if I'm wrong, but like Klonopin is a better option than Xanax.
Absolutely. I mean, it's a longer acting. There's a lot of options here, and I think,
And
Liz
I
and
think
Chris,
that's important. I think
yeah,
most psychiatrists would say,
yeah,
oh, Klonopin wouldn't
yeah,
concern me as much, but Xanax 3 times
yeah.
a day would.
Well, I think your answer, Liz and Chris, beautifully highlight that this is a conversation, right? And so you're seeing in the end of the statement that he hit a brick wall. So there's been a loss of hope. There's been a rupture there that we don't want. We want to engage people in treatment, let people know there's lots of tools and there's a lot of different providers, and you got to find the one that's right for you. So maybe this provider wasn't a good match for your son. That doesn't mean that to give up hope, right? And
Right.
and you just heard, Liz beautifully. I'm convinced I would get, maybe hearing the rationale and the goal setting the way Liz articulated beautifully, then your son could align with that, or there's other ways.
That's right. Yeah. 4 more questions, Chris, then we're on to you. In the past, I was on 200 milligrams of Zoloft for OCD. Currently, I'm taking Crantum and was thinking about starting 50 milligrams Zoloft again. I'm seeing they shouldn't be taken at the same time and at least 2 hours apart to avoid serotonin syndrome. I can't find a whole lot of information on it, but is this recommended?
What I can speak to is that there haven't been randomized studies of kratom in OCD, and it is not an FDA approved medication. So, I would definitely consult with your psychiatrist and see if there are other options. It's hard for me to weigh in on specific recommendations because I don't know the context. So it's important to know the history, what you've taken. But I would not recommend. There's no evidence base for kratom.
Perfect. Thank you. Next question. Other than ERP and SSRIs and SNRIs, are there any other recent alternative psychiatric treatments that have shown to be effective to reduce OCD?
Mhm.
Ketamine, CBD, medical marijuana. We get a lot of questions about psilocybin and things that are in the news. So this is a great
Yeah.
question.
And
Yeah.
supplements is a big one too. Yeah.
Supplements, yeah.
Definitely. So, what we know of the evidence base is that supplements like St. John's worts have not been shown effective. There are no studies showing that marijuana is effective in OCD. There are researchers who are studying it in endocannabinoids, but there isn't there isn't an evidence base for that. Um, I would say. That another class of medications that can be used in augmentation are glutamate modulators. So I mentioned one, which is memantine, which has a nice evidence base. There are also ongoing research into medications like N-acetylcysteine, riluzole. There's a large study of troriluzole that a drug company is sponsoring. Looks like it has some promising results and is now in phase 3 studies. So that looks promising. I've conducted research study of ketamine compared to saline for OCD in a small pilot study. And we just finished a larger NIH funded study of 5 years, which is comparing ketamine to midazolam, which is an active control. So it's a better comparator. And so those results we're preparing for manuscripts, so to be continued. But I don't think that ketamine right now has the evidence base with just one study that we conducted. We like to see larger and replication in order to be able to say that is efficacious.
Next question. And we're getting there, I promise. Thank you, guys. We talked about antipsychotics already, so I'm going to skip that one. So the last one is, why do some psychiatrists downplay the importance of a gene site psychotropic DNA test? Why wouldn't you want to pick from drugs in the green zone first versus drugs in the red zone with significant gene interactions? And maybe you could talk about what that would mean, but then also why this may or may not be relevant in medication decisions for OCD.
Definitely. So I'm part of the American Psychiatric Association Council on Research and a Biomarker Task Force. We put out a nice publication on the evidence base for these kinds of genetic tests. And what we found is that these tests are not at the point, which is sort of the aspirational goal, to have somebody in front of you take a test and be able to say, this is the right medication for you. But what those tests are good for, if they do this, is to see if there's liver enzymes. So there's a P cytochrome 450 mechanism that makes people metabolize drug faster. So you may need higher doses of the medication. And so that is actually really helpful. But there isn't a good, strong evidence base that these kind of tests will be able to tell. So we're still looking at trial and error. And I think the reason why individuals may be of two minds about it is because it can help in terms of the metabolism, but also you can just do a trial and error. So the question is, do you need to do an expensive test?
Thank you. I'm going to jump into the first live question. It was at 12:04. Their son is on fluvoxamine, about 150 milligrams, and they're sleeping 13 hours a day and really struggling to wake up. Could it be the medication, and how would they know maybe that they need to move on or do something different if this is the effect that they're having?
Sleepiness is a side effect of medication, and so I would definitely recommend circling back to the provider and seeing if the dose can be, you can certainly titrate down the dose and see with your, again, in conjunction with your provider. And you can also try other medications as well to see if it doesn't have sedation. One thing that just makes me concerned, and again, I don't know the full story, but sleepiness can be an effect of medical things as well. So I think it's definitely worth going to the psychiatrist, but also the primary care doctor to check simple things that you can do on a blood test, like thyroid tests. And if there's any other signs of illness, that can be the case as well.
Perfect. Billy Myers at 1209 asks, is there any evidence that Desven Lefaxing is effective in treating OCD?
Mhm. So I think, again, that ADAA uh, sort of clinical trial algorithm has a listing of all of the drugs that are FDA approved. So those include fluoxetine, fluvoxamine, paroxetine, and sertraline. Um, Escitalopram and citalopram are not. Venlafaxine, mirtazapine, and desvenlafaxine are not FDA approved. That doesn't mean that they can't be tried and they can't be helpful, but just so you know what the FDA listing is.
And then the next question was, sorry, it moved. It was from, thank you, 1214 from Lorena. Um, are there any tests? I know there's Amen Clinic is one that does like scans on the brains. Is there any evidence that scans on the brains or any other brain tests that are effective? What Lorena was saying is like, obviously we have tests if you're having a heart problem or other parts of the body. Is there any kind of like brain testing to show that somebody might have OCD or any problems with the brain?
No, no, there isn't. We don't know what causes OCD, and we don't have any brain scans that can provide a diagnosis of OCD. Really, is a clinical diagnosis. But there are researchers who are very interested in these kind of questions, foundational questions. Is there an EEG signal? Is there a marker? Is there some kind of scan that can be helpful? But as of no, no.
Thank you. 1220 we have from Deepak. Is it possible to recover only from CBT if done properly without medication after trying for 11 years? I'm not sure if they've been trying the medication for 11 years, but I'll make this a two-part question because this we get a lot. If somebody's been trying different medications for 11 years, because I know sometimes people say, I've tried every medication and they've spent 4 months trying. But the first part of the question is, if somebody's tried medications for 11 years and haven't seen any benefits, what would they do? And then vice versa, if somebody's been doing ERP for 11 years and not seeing relief, would that be time to maybe explore going on medication?
Mhm. Um, it's hard to know without having the full context, but what I will say is there are individuals who aren't helped by first line treatments, have tried a lot of things in the sort of standard toolkit and even augmentation strategies. And so again, that requires a conversation with a psychiatrist. There is FDA approval for transcranial magnetic stimulation, which is a brain sway coil. So that's been FDA approved. That's another possibility. And there are surgical alternatives called deep brain stimulation. I don't like to go down the surgical route because there can be risk of bleeding and infections, but there are some people who are not helped, and they have really tried and all different manner of routes, doses, and higher level of care, and they can be helped by these surgical interventions.
Thanks. We have a question from Michelle Hoffman at 1225. She says, is emotional blunting rather a real side effect? All the changes her son has experienced seem to mirror those emotional blunting. What do you recommend that we do at that point?
Mhm. Yes, that can be a side effect. Can also be called anhedonia. It can also be a symptom of depression as well. So that would be one thing to just kind of circle back to the provider. Is there a mood component also? It's not uncommon for people with OCD to also have mood component, and they just don't. They people that have anhedonia, it may be a side effect. It may be just feeling like they don't have that interest in friends and activities and day-to-day life. And so it's important to also monitor for co-occurring illnesses and as well that can be treated both with therapy and with medication.
Yeah, she was saying her son is just showing kind of like a lack of motivation, lethargy, and like the larger questions. So thank you. We talked about this a little bit, but maybe expanding on 1241 from Asil. I My name's so bland and Chris, so I'm always fascinated by awesome names. It's S. Leo Seo. They said, how do you know if a patient needs to be on medication for a lifetime or not?
Mm. Um, I think that's a tough question. But what I would say is some contributing factors are people that have been on medications and then come off of them and relapsed. And if that happens several times, just like depression, it may be that that individual might want to consider staying on medication. At least in depression, we know that the more relapses, the higher the chances are that people will need to stay on that medication. So that's one factor. But again, close coordination with the psychiatrist and understanding the circumstances.
Felice Becker asked, because I know Liz had mentioned in a question, what about the latest research on psilocybin? That was at 1248.
Yes. So psilocybin is an interesting compound. So that is considered a classical psychedelic, and it is an agonist of the serotonin 2A receptor. And there have been promising studies by Moreno et al. Out of Arizona. The Yale group has been having some promising data, and there is going to be a trial. A drug company is going to be sponsoring a larger study to really examine this in OCD. So I think that's one to look out for. There's not enough evidence base to suggest yes, right now you should do this, but it is a thread of research that people are taking up.
I'll do one last one because I want to be conscious of time. It's from Michelle Hoffman again at 1224. What happens if somebody starts to see concerns that didn't exist before the medication? So whether that's like a side effect, but her question was more about struggling with like memory or different things, behavioral that they've seen changes. Is how do you know when, hey, maybe it's time to change if people are showing new difficulties in functioning than before they started the medication?
I would say to look at the timing with the psychiatrist. So if there's just recently starting a new medication and something is amiss, that would point to this to be having it be specific. The other thing is to look at in doses, increase in doses or additions of medications. Maybe those two medications aren't working well together. So those points are. But if you've been stable on a medication and all of a sudden you're getting something new like lethargy or pain somewhere, then that would indicate to me more, let's go back to square one. Let's do a full physical. There are medical conditions that cause these things, and we don't want to miss anything medical because we're attributing it to a side effect of a medication.
Awesome. I got to most of them. There's one more that I was going to ask, but I looked at the time. So what we'll do is we'll save this, and I'm going to open an invitation, Carolyn. Like if you ever want to come back, we'd love to have you. We get a lot of medication questions, so that's kind of amazing to have you today. We finally got to a lot of them, so I know Liz and I feel a lot better because feeling bad.
They've been piling up, so we love having you here.
I'm happy to anytime, and you know it is humbling, right? You know there's so much that we don't know. And, you know, I really have equipoise. I think it's important to do research study to answer questions that people have, to understand what to do. Like, for example, I did a plenary at IOCDF on psychedelics, right? And one class of medications called entactogens or MDMA. There's no study in OCD, and we got funded by Foundation for OCD Research to do a study of MDMA versus a really amped up control to answer that question. And I have no stake in it. Like if it's negative, that's great news because then we can tell people. If it's positive, then it's another one of these little threads to follow up.
That's right.
You know what? Liz pointed out that I missed a question, so I feel bad. So I'm going to ask it real quick. How much time does it take for fluoxetine to start working, and how to know that it's starting to work?
So we think of like 4 to 6 weeks at the maximum tolerated dose, but somewhere between 8 to 10 weeks, sometimes out to 12 weeks is the recommendation for SSRI class.
Awesome.
Perfect.
Well, we are so grateful for you, and this makes such a difference where people are saying, please come back. Well, we're going to watch the replay and et cetera, et cetera. So we're just grateful. And I'm grateful for two things that I just wanted to say thank you for: your knowledge, experience, your willingness to share it with the community, and also for your dedication and work in furthering to advance the field. So both things are something that we hold so close to our heart, and we're so grateful for. And I'm hoping we'll see you at the conference in Denver in just a few weeks.
You will.
Great. Well, so we will see you there, and hopefully we'll see so many of you. Any final words that you have, Chris, as we wrap up today?
Yeah, two quick things. One is I saw a lot of non-medication questions. So we have this amazing worker at the IOCDF known as Skyla. So Skyla is going to kind of save those questions and we'll add it to our list for our next live. So we won't be back next Wednesday. That is Research Roundtable, but we'll be back the following Wednesday at 9 a.m. Pacific, 12 Eastern. So if you asked a non-medication question, we're on it. Come back in 2 weeks and we'll answer it. So great. And then second, I'm just going to be annoying about it until the day of. Please come to the conference, y'all. I think the in-person conference is life-changing. It's where I met Liz when I was an absolute OCD mess, and she gave me inspiration to fight OCD. You're going to find somebody you connect with. So please, please come to the conference. And a little birdie told me that today you can still get the early bird registration. It's the last day. So please, please, please do early bird. If you're going to go, might as well save some money, but Liz and I want to see you.
Nothing like it. It is so great to be together with this incredible community, to learn, to live, you name it. So definitely be there. I'll leave with a message of hope, which is that hope and help are always available. No matter what you're struggling with, we can think about ways we can augment medication, behavioral therapy to get you the best outcomes. Dr. Rodriguez, any final thoughts or questions or comments from you?
I think you nailed it. There is hope. There's so much promise. There's so much research. There's so many people, the three of us, and many, many more that you can't see who are just, our lives are committed to this, and we want to help.
100%. Thank you for your time. Thank you all for joining, and we will talk soon.
Bye, everyone.